Good afternoon, everybody. I hope you had a fruitful lunch discussion with your colleagues, and our first presentation this afternoon is from the role of gynecological findings in ICBPS, and Marie is going to present. She's the junior researcher for the team. Professor Savigny and Amar are the discussants. Kelly? Where did Kelly go? Come up.
Okay. Thank you. See, when I press here, it doesn't. You're the best. Okay. Thank you, Dr. Badlani. Thank you all. I'd like to start by thanking each of my wonderful committee members who have made such thoughtful contributions to this consensus statement. I'm Marie Sullivan. I'm the first-year urogynecology fellow here at Wake Forest, so I have the honor of working with Dr. Evans and Dr. Badlani and Dr. Walker, and I'm really excited that you all are here with us today. I'd also like to comment that this is a living and breathing document that's gone through multiple iterations and is currently undergoing revisions to the point where we all updated this during lunch. So please understand that this is very dynamic. The main point of our consensus statement is that a number of associated gynecologic disorders may overlap with ICBPS or be mistaken for it, necessitating careful differentiation as to whether they are the cause or the comorbidity. We have multiple chronic pelvic pain symptoms, and ICBPS is a common cause of chronic pelvic pain in gynecologic patients and should always be considered in the differential diagnosis. The challenge in both clinical practice and in defining a classification system, as we've been kind of struggling through, is the extent to which other pathologies can be responsible for the symptoms and rule out a diagnosis of ICBPS. So in this context, it should be remembered that ICBPS is commonly comorbid with other types of pain and is included as a chronic overlapping pain condition. The majority of our focus in this consensus statement is going to be on diagnoses instead of symptoms. Some of the comorbid gynecologic diagnoses that we'll review are written here. We're going to go through one by one. So the first is genitopelvic pain disorder. Up to 75% of women with ICBPS report that sex worsens their symptoms. Among women with lower urinary tract symptoms, those with an official diagnosis of ICBPS reported higher levels of sexual dysfunction. And sexual function, particularly in relation to pain, has been shown to significantly impact mental quality of life in women with chronic ICBPS. In a case control study of 215 ICBPS patients, you can see that they have significantly more dyspareunia, more fear of pain, less sexual desire, and less ability to achieve orgasm when compared to controls. When we're thinking about sexual dysfunction and genitopelvic pain disorder, we have to think about both superficial and deep dyspareunia. So superficial dyspareunia is usually associated with vulvar or vestibular symptoms, and deep dyspareunia is more of a visceral pathology or endometriosis. Both of these types of dyspareunia are concurrent with ICBPS. We also see vulvodynia and vestibulodynia as a comorbid condition and also exacerbator of ICBPS. Embryologically, the urogenital sinus gives rise to the urethra, the bladder, the distal vagina, and vestibule, suggesting that a disorder of the urogenital sinus-derived epithelium could lead to concurrent pain in both the vestibule and the bladder. Among patients with ICBPS, the prevalence really varies based off the source you're looking at, but can range from 25 to 85% of these patients. Vulvar pain can be localized, where you have vestibulodynia or clitoridynia, or generalized as just a generalized vulvodynia Can be provoked during tampon insertion, sexual activity, speculum exam, or spontaneous. And historically, this was referred to as vaginismus, but this is an outdated term at this point and has been replaced. We're thinking about vulvodynia as a multifactorial condition with pathologies including hormonal influences, genetic factors, inflammation, musculoskeletal issues, central and peripheral neuropathic mechanisms, psychosocial factors, and structural abnormalities. Vestibulodynia has been associated with increased mast cell activity. Up to 61% of individuals with vestibulodynia report at least one comorbid condition linked to mast cell activation. Abnormal mast cell activation and neuropathic pain is central to the pathophysiology of both vulvodynia and vestibulodynia and ICBPS. In the bladder, mast cells are stimulated by substance P, which then triggers that histamine release and the activation of other inflammatory markers, ultimately resulting in the hyperalgesia and neuropathic pain that has been labeled the wind-up cycle. This mechanism can extend beyond the bladder, affecting the peritoneum, the bowel, and the vulvar and vaginal regions. Overactive pelvic floor, which others might know as high-tone pelvic floor, non-relaxing pelvic floor, fixed pelvic floor, and pelvic floor tenderness, is something we've all kind of alluded to earlier in this conference, so we're going to speak a little bit more about it now. The diagnosis of overactive pelvic floor is often confirmed during a vaginal exam, where the clinician is palpating a top band or the patient is perceiving tenderness in the muscles such as the levator ani, obturator internus, piriformis, and coccygeus. Dr. Meister and their team developed a standardized and reproducible pelvic floor muscle exam protocol to help clinicians diagnose and assess the severity of overactive pelvic floor dysfunction. The photo here on the right is kind of explaining that and was published in AJOG. As many as 85% of patients with ICBPS are diagnosed with overactive pelvic floor muscles, which is pretty startling. There's a couple different perspectives as to why these overactive pelvic floor muscles develop. The first is the biomedical perspective, where this is a result of altered voluntary activation or reflex control. The pain associated with genitopelvic pain and penetration disorders or vulvodynia can trigger a reflexive muscle tension as the body attempts to shield itself from perceived pain. A small comparative study observed significantly higher pelvic floor muscle resting EMG activity in the ICBPS group, along with shortened pelvic floor muscles in 80% of women. There's also the biopsychosocial perspective, where you have this anxiety or learned guarding response to experiences such as chronic pelvic pain or trauma. And the intersection of ICBPS and overactive pelvic floor muscles is complex, often influenced by a combination of anxiety, trauma, injury, surgery, and lifestyle factors. When pelvic floor muscle tension becomes chronic, it perpetuates the pelvic pain cycle, creating a vicious feedback loop where pain and muscle tightness intensify each other. This results in a complex and challenging clinical scenario where it can be difficult to distinguish whether the pain originates from the muscles, the bladder, both, or another underlying condition, further complicating diagnosis and treatment. Lastly, we'll talk about endometriosis and adenomyosis, which I want to just define briefly for those outside of the gynecologic world, as they can seem a bit confusing sometimes. Endometriosis is this presence of endometrial-like tissue outside the uterus and is considered a chronic estrogen-dependent inflammatory condition. Adenomyosis, on the other hand, is related to endometriosis, but there's endometrial-like tissue found in the myometrial layer of the uterus. ICBPS and endometriosis has kind of been termed this evil twins phenomenon, where the two overlap quite significantly. And this overlap includes abnormal mast cell activation with a release of pro-inflammatory molecules that contribute to pain, neurogenic upregulation, and visceral hyperalgesia. Prospective studies have reported an overlap between endometriosis and ICBPS in up to 65% of patients in some studies. It's very well established that these coexist, as we talked about, as kind of that evil twins phenomenon. In some cases, endometrial implants involve the bladder. However, many do not have endometrial implants in the bladder or peritoneal bladder implants, indicating that the mechanisms at play may be much more complicated than we think. Patients with ICBPS and endometriosis have a large bladder capacity, increased incidence of chronic fatigue, fibromyalgia, migraines, pelvic floor dysfunction, and all of these findings are consistent with the systemic and not bladder-centric phenotype of ICBPS that we previously heard all about this morning. This slide here is really not doing justice to all of the wonderful work we have in our manuscript about these confusable versus comorbid conditions that we also go into in quite a substantial amount of detail, but I wanted to make sure that everyone saw that there are many other things that we're thinking about that are related, that I'm not going to go into full detail, but pelvic venous disorders, large leiomyomas or fibroids, infectious etiology, genitourinary syndrome of menopause, prolapse, post-op pain, and pudendal neuralgia are all things we need to be considering as causes of chronic pelvic pain in both a comorbid with ICBPS or maybe masking as ICBPS. And lastly, there's a great deal of overlap between ICBPS and many psychosocial and somatic comorbidities. Although these are not gynecologic in nature, it's important to treat them because symptoms of ICBPS will not improve if these underlying disorders are not also managed. A history of sexual trauma or adverse childhood experiences or events are very associated with chronic pelvic pain and ICBPS as well. And then comorbidities such as fibromyalgia and IBS and migraines can overlap or exacerbate ICBPS symptoms. That's kind of our brief overview of our manuscript, but we welcome feedback and would love to hear your thoughts on other things that you think would be relevant to include or things that you think are not the best. Please let us know.
It's so tall. So Rachel Rubin presents on the strip of vulvar tissue, the endodermal stripe between the hymenal remnant and Hart's line, and that's testosterone sensitive. And she points out that women with vulvar pain in that region, concurrent with bladder pain, there's a link because of the endoderm, because the bladder is of endodermal origin. Yeah. So I think that's a really important thing to look at and to research, and I'm curious about it, but I haven't read about it. Does anyone have information about that, and is that an area that we should explore or comment on in this document?
Yeah, I think that's a great point. I mean, Rachel Rubin's one of my icons, so I really love her and the work she's doing. And one of the things that's further discussed in our manuscript are kind of the hormonal changes and what is the utility of a vaginal estrogen. We haven't looked at vaginal estrogen and testosterone specifically, so I think that's interesting that we could do further research on. Yeah.
Has anyone seen any substantial publications on that? Yes, I use it a lot too.
Right, yeah.
Hi, Dick Jensen. I'm missing from the whole table, I see a lot of patients also with really bladder pain syndrome, Honda lesions, those kind of things, with lichen sclerosis, so vaginal problems.
Like dermatologic conditions.
And the second part, I think it's really important to say, okay, what's what? So I think a lot of these issues create pelvic floor disorders and create all these other types of things, but to refrain from compounding, like you have bladder pain syndrome that can cause pelvic floor disorders and create all these other different things. So that's the scale-on effect from bladder pain syndrome in the cascade. But now it comes across that all this like endometriosis can cause interstitial cystitis and so on. So I think it's really important to differentiate what's chronic pelvic pain and pelvic floor disorders, and those are the other gynecological things that can also aggrieve this or make this worse. But it really is needed to separate the symptoms from a better say, an interstitial cystitis patients and other correlated diseases, and it's not the one big mashup. So, and I think from now on, it's a bit of confusing what's what.
Like symptoms versus diagnoses?
Yeah, and also that IC is correlated with endometriosis, I don't know, but I think IC is a different type of condition, a disease, or anything like that, but and it creates pelvic floor problems, and that's the chicken and egg story. And now it comes across that, okay, that the endometriosis has a relation to bladder pain syndrome and actually an IC and so on. And I think that's a difficult one to prove or to show.
Yes, the problem is that those patients, we need to consider that the majority of IC patients are female, yes. 5-1 or 8-2. And they need to have a specific approach, mainly by urologists. They have also a culture on gynecological sign. That means I agree with you that we need to focus mainly, and there are several aspects. One of them, for instance, in pelvic endometriosis, is to make a combined cystohydrodistension and diagnostic laparoscopy. There was a very interesting paper published by Howard in more than 1,500 cases of pelvic pain in gynae traditional pelvic pain patient, and they discovered pelvic endometriosis in more or less 30%. The other was related to the pelvic inflammatory disease, the other about scar, and 35 without any particular problem, which is the main aspect, that 30% that it was referred to the bladder. That means that we need to combine in patient with chronic pelvic pain and suspected IC also, and we do, in our department, we do a combined diagnostic laparoscopy, because I agree that a simple sign cannot distinguish among the different situations. This is one. Another one, for instance, is about pudendal neuropathy, because now is a fashion that patients with the chronic pelvic pain, they are referred to as pudendal neuralgia. There are specific signs. One is the tinel sign, that means to evaluate with the finger into the ischial spine, to evaluate the pain in bilateral. And the second sign is the rolling test. The rolling test means to roll the skin of the perineum, and there is a discrepancy among one side to another side. This is another important sign. If you have the suspect of pudendal neuropathy, then now there is the possibility with the MRI to make the root of the pudendal and to see if there is a pudendal entrapment. Or you can make a ultrasound with a Doppler ultrasound to see the reduction of the vascularity of the pudendal artery and veins. These are three signs just to explain the confusable disease, for instance, for pudendal neuralgia. That to say that they need to approach in a different way from, for instance, from male patient, because they need and finally, physical exam, please, physical exam. We need to evaluate the pelvic floor of the patient, absolutely. Just evaluating with a pain mapping on the trigger point in the levator and eye muscle, in the pubococcygeus, stecoccygeus, and obturator. This is absolutely mandatory.
I think you're completely right in this. It's mostly also for finding confusable diseases and say where the pain actually comes from. Because a lot of patients I get referred to, like this is suspected or they have already diagnosed with bladder pain syndrome, which are not an IC patients. These are just chronic hypertonic painful pelvic floors and so on. So I think it's really important to do all these exams and treat all those patients. But this also needs to be done to remove or to, so they say, to research that it's actually not, sometimes a lot of cases, it's not an IC patient, but the pain and stuff comes from somewhere else in the whole gynecological tract, for instance. So I think that's really important for everyone to understand that, okay, not all patients with pain in this area and have some relation to the bladder is an IC patient. It can be just a chronic pelvic pain patient.
Okay.
Okay, thank you so much. So you partly answered my question about the evil twin that is there in the pelvis, the endometriosis and the bladder pain. My question is, how would you suggest a simultaneous laparoscopy? When will you suggest simultaneous laparoscopy with hydrodistension in a given patient? You may have indications, we just want to learn.
Yeah, there is a precise indication when there is some LUTs during the flare of the menstrual cycle, the irritative symptoms, and chronic pelvic pain. This is the indication to combine the cysto hydrodistension in a general anesthesia and diagnostic laparoscopy. And another important sign, they refer to the MRI, but MRI can distinguish with the big endometriosis cyst or scar situation. But in the mild situation, the MRI cannot demonstrate, and that's the reason why just last week I do in a young woman with suspected IC, and there was a negative MRI. I suggest to perform a combined diagnostic laparoscopy, and there was a sign of endometrial implants into the Douglas pouch above the peritoneal of the bladder. And obviously, I treated.
Yeah, so my question next is, would you give a trial of hormonal manipulation before you go to laparoscopy? Suppose for these mild patients, you could have simply given a therapeutic trial of hormone manipulation so that the endometriosis is suppressed, the pain is gone, and make a diagnosis, or would you go directly and do a laparoscopy? So this is... I
am not expert on endometriosis, obviously. I have a little concern about hormonal approach on those young patients because the hormones treatment doesn't have great results, poor results. And the side effects are enormous for the young patient. It's much more interesting to approach directly to endometriosis, to endometrial implant, because this is important. Another different aspect is about adenomyosis. Adenomyosis is really a big challenge. Because why? Because in a young woman, they want to have a delivery, you have a pregnancy, and if there is an implant into the inside the uterus, it's difficult, and the pain, believe me, is very strong. It's confusing, really confusing, and you need to take care. And in this case, the MRI is completely elucidating the problem, because
and laparoscopy can miss it.
Yes, absolutely. Laparoscopy missed.
Can I comment on his question?
Yeah,
Since
yeah,
I
yeah.
do a lot of endometriosis. So the ACOG guidelines about trying hormonal treatments to get the diagnosis of endometriosis, for us here at least, most times we do get patients, they've already had treatment of some sort, just in the form of birth control, something like that. So for me, the reason I would do laparoscopy is if they come with pelvic pain and there is any suggestion of endometriosis, anything that is cyclic, if they've had actually birth control in the past that's worked for them, so then I am suspecting endometriosis. Typically, if we're going to the OR, they're getting a laparoscopy. And I feel like picking it that way, it's usually 80 to 90% positive when you get in there.
So my comment has to do with the concept of comorbid conditions versus confusable or et cetera. I mean, in the context of a meeting that's about IC, if we take it from that standpoint where we generally are talking about patients who have IC symptoms, I think these would all fall into the comorbid category. But what is, of course, important to acknowledge is there are times where if one of these, quote, comorbid conditions is treated and we thought they had IC, they get better. And so I think that's where I think the idea of confusable comes in because, well, maybe we were wrong that they had IC and it was all their, endometriosis or otherwise. I guess, so that's a comment. I'm wondering if you agree with that. And I guess what it would mean that potentially, all of these conditions you listed there, I would consider comorbid as really what we're talking about here. And that may also clarify as we kind of talk about, terminology and things.
I think the idea of all this paper is to be aware of the comorbid, which can be comorbid or confusable. So it can be and or, it's not necessarily like one or the other or mutually exclusive, but just to take a more holistic approach to pain patients and understand that, yeah, they may have IC, they may also have something else, or you may be missing the big picture, which could be a treatable disease that's not IC, for example. So I do think all of that is true, all of what you said.
So my comment relates to vulvodynia part. So in the morning session, we talked about lidocaine for ICPPS. For vulvodynia, you cannot use 2% lidocaine for pain relief because vaginal epithelium is less permeable. So you have to use 10% lidocaine for differential diagnosis of vulvodynia versus IC, because 10% lidocaine will relieve the pain of vulvodynia, but 2% will not. That's one point I want to come up.
Sorry, but I have no experience on that because I don't think that the specific treatment, local treatment of vulvodynia start from since a long time before. So I think the simple injection locally of anesthetics cannot relieve only temporarily and cannot distinguish refer vulvodynia, simple vulvodynia, from associated with IC. And as has been presented, there is a strong correlation between vulvodynia patient, because the majority, you need to understand that the bladder can interact directly.
I didn't mean injection. I meant application, topical application. I was bringing up the permeability difference between vagina and bladder.
I know.
Yeah, that's all. So don't bring up the injection. That's why what I was saying was vagina, you need 10% lidocaine. Bladder, you can do away with 2% lidocaine because bladder is more permeable. Vagina is not. So to vagina, for pain relief, you need 10% lidocaine. There was a study done in France. They used 2% lidocaine. It didn't work. They jumped to Botox. They could have give pain relief at 10%. Point I'm going to bring here is the permeability. Since morning, this way, at least permeability message I want to convey.
Yeah, the problem is that the overlapping of all the pelvic floor situation are so with the interaction among them that there is an interfering with one part and the other one. Respect to the final aspect of the vulva, the vulvodynia and the vestibulodynia specifically, there is an increase of mast cell, but we now know that mast cell are only the final effect but not the cause. And so if we have a reduction on this sense, because, for instance, there is one crazy action for vulvodynic patient. There are some group of gynecologists, they remove the vestibulum of the vagina. And this is crazy for me, because it's not removing the part of the vagina. And in fact, there is a recurrence on the pain. That's the explanation. The problem is behind, because there is when there is a long term of the effect, there is a centralization of the pain, and so the periphery cannot resolve the pain. Absolutely.
But if you treat the periphery, central will not happen. That's what I'm trying to bring up. If you stop the problem at the source, the central sensitization will not occur.
And we did a study that after 1.5 years, there is a centralization of a patient with PPS from periphery to the central situation and the centralization.
Can I just add something about the endometriosis side of things? So I think it's really important to be aware that there are about 1 in 10 women who have endometriosis, but that for many of these, this is asymptomatic, and that we know that the location and the severity of disease that we identify at laparoscopy does not correlate with symptoms. So you can have urinary symptoms but not have endometriosis anywhere near your bladder. So I think we just have to be really careful about assuming that everyone in whom we find a small red lesion of endometriosis, that the endometriosis is the cause of their symptoms. And in terms of whether we should treat surgically or hormonally, I think at the moment the jury is out as to which is the best. But we know that dysmenorrhea alone, whether there's underlying pathology at all, causes all sorts of alterations, including visceral hypersensitivity, central nervous changes, and therefore actually a long-term hormonal approach for something that's going to be a chronic lifelong condition that stops menstruation and stops repeated episodes of dysmenorrhea is likely to be a more effective long-term solution. We can't be doing annual laparoscopies for people when we find 2 lesions of endometriosis in their teens. So thinking about sort of mild superficial peritoneal disease versus sort of the more complex deep disease where we might want to be operating for other fertility-related regions or protecting their kidneys, I think we've got to remember that it's quite a heterogeneous condition.
Yeah, endometriosis, I always say is like the IC of the gynecologist. I mean, it's pain, there's pain. And, what I'd like to see consistent, and I don't in the United States, is if they're going to have laparoscopy, that they actually biopsy. They see these little red areas, they'll take some pictures of them, they laser them away, but they never make a pathologic, or rarely, make a pathologic diagnosis that this truly is endometriosis. And as was just stated, there's people who get just diagnostic laparoscopies for tubal ligations who can have a pelvis full of endometriosis and have no symptoms, yet we think that if we go in there and see 2 little red dots that somehow, that's their pain. And if you treat it, whether it's hormonally or excising it, or if it's deep or invasive in the bladder, and they get better, it brings back the same question I had, and that I think that, that has been alluded to is, do they have interstitial cystitis bladder pain syndrome? And this is why I think the diseases that are treatable, we should treat. And then if they still have pain with bladder filling and frequency and urgency, then it's ICBPS. But I think if we don't do these additional treatments for pelvic floor dysfunction, for pudendal neuralgia, for endometriosis, if all their symptoms go away or their bladder symptoms are now gone, it wasn't ICBPS, and do we do them any good by labeling them with that? I'm harping on the same thing. I think there's lots of reasons why people have pain, and we're so easy to just put it into IC, and I'm just not convinced that that's the right thing to do.
A comment about the pelvic endometriosis as well as the IC, that they are chronic syndrome or disease, and unfortunately very difficult to manage and to treat, because pelvic endometriosis, I exclude the endometriosis outside the pelvis, because there is also endometriosis in lung and in the skin and so on. But pelvic endometriosis has the same medical history as well as the IC, as well as the vulvodynia, are chronic debilitating disease without the medical community currently has obviously new tools, but not so efficiently respect to the desire of the patient. And endometriosis, I agree, I don't believe that medical treatment can be the real effective success for the patient, because the symptoms of pain, of discomfort, or dyspareunia, or also irritative symptoms into the bladder, excluding IC, are very, very critical. And one solution is the analog to impede the menstrual cycle to hormonal blocks, but there are a lot of side effects, including the early menopausal situation with the vaginal itching, vaginal drying, and so on.
You can do it temporarily, just if their pain gets better, if their IC pain or pelvic pain
Yeah,
gets better,
yeah.
at least you say, okay, that's probably the endometriosis. Let's figure out how to manage it. And if it doesn't, or often, people are said they have it, but it's not cyclic pain. I mean, I feel like, there is ways to look at these, like your vestibular, doing a vestibular excision. I mean, it's clearly helpful in a subset of patients who have primary vestibulodynia. If you have a vestibular exam at 5 to 7 o'clock and associated pelvic floor dysfunction, treat the pelvic floor, the vestibule gets better. Treat the pudendal nerve, the vestibule gets better. But if it's a primary kind of around the clock and nothing else is working, I mean, I don't do it, but I've certainly seen patients who get it removed and get markedly better.
Listen, is the same as the anal lesion. The anal lesion, if you remove or treat the anal lesion, there is an improving of symptoms, no doubt. Any common results. The same with the nodules of endometriosis. If you make a removing of the nodule endometriosis, the pelvic pain disappear. They are completely free of pain.
I want to try to peacekeep a little bit in that I think it would be wise for us as a large group to come to some consensus about how we present this idea of confusable versus coexisting diseases, because I think you both need to, if there's stuff that you can treat and you can treat it easily, I totally agree. I think probably if they all got pelvic floor physical therapy, a lot of them would get better, and then you could sort things out a little bit better. But I also get worried every time I see a table that has prolapse in it, not to be problematic, but like prolapse is not causing the syndrome that we all recognize. And when you start doing that, I'm sure you all have, just like me, seen the tremendous number of patients with, a 3 centimeter fibroid or a stage 2 anterior vaginal wall prolapse that have been treated for those conditions and who now are in your clinic with much worse pelvic pain because they just had pelvic floor dysfunction to begin with and then they got operated on and now they're even worse than they were to begin with. So I would just be very careful to, when we present these, we have to say there are things that can coexist, there are things that can be confused with it, but the symptoms have to be in line with the things that we're trying to treat. So, a vestibulodynia is, to me, looks very different than a pudendal neuralgia. I don't think it's that hard to tell the difference between those things, but you don't want to attribute to vestibulodynia somebody with back pain, like that doesn't make sense. So things have to be just in line, and I think we can come to some consensus on how we present that to talk about things that can coexist, but those coexisting things have to be reasonable to explain the patient's symptoms. I think that's all I was going to say.
I just wanted to follow up on that. I had the question too. I never saw the gynecology patients, so I got together with 5 gynecologists spread out across the United States. And let's find out. So they did a study where they would clinically diagnose the patient and then give them a potassium test. That'll answer the question today. You don't have to wait 6 months for therapy. And guess what? About 65% were called chronic pelvic pain, which is probably real because they don't know where it's coming from. 22% had documented endometriosis, and about 12% had vulvodynia. they were all positive. 85% of all those diagnoses were potassium positive. And one of them in follow-up, an expert in vulvodynia, he had 125 patients he tested and screened them for symptomatology, bladder symptomatology. 90% had frequency and 85% were potassium positive. So it looks, their paradigm was turned upside down by this. The least common diagnosis in the first studies was 1% IC. So that will really, that's scientific evidence that'll answer the question in one visit.
All right.
Just I would like, only I would like to congratulate officially with you because this is the third consensus meeting. The first was done in 2003 in Japan by Tomohiro Ueda. The second one in Rome by myself in 2012, and more of people here, they were attended, and this is the third one. Thank you.
I'm sure it won't be the last, based on the lack of consensus. So let's work harder at defining things that we can agree on. I'm sure there are more things we can disagree on, but one of the follow-ups tomorrow is to find maybe small increment steps that we can agree on and perhaps come up together as a consortia to validate some of those simpler things that we can agree on. So that's clearly the goal, not going to solve every issue. So the next talk is from Henry Lai on etiopathology. He's going to cover all the 5 committees before him. Henry, welcome.
Thank you. It's nice to be able to present in the afternoon because it looks like just about everything I'm going to talk about, you already heard it this morning from the various committees. So it might be a little refreshing, a little bit easier to go through the information. So our committee is charged to look at etiopathology. And what we decided to look at is etiology and pathophysiology of the different phenotypes that we've been talking about this whole day. And these are our committee members. Max is one of the residents at Wake Forest. He has done a wonderful job putting the manuscript together and some of the diagrams, so he's not able to make it today. But I want to give him a hand of applause for Max. He's done a great job. So pathophysiology of the different phenotypes. I don't need to tell anybody that IC is a heterogeneous syndrome with many different phenotypes. We went through this morning. The 2 big categories is bladder-centric phenotypes and widespread pain phenotype. And among the bladder-centric one, we have talked quite a bit about Hunter's lesion phenotype and the one with low bladder capacity. Now, I'm going to not talk too much about pelvic floor-centric phenotype. It's clearly there. We know that at least 2/3 of our patients have pelvic floor dysfunction, high-tone pelvic floor dysfunction, pelvic floor tenderness. There's good treatment for that. We get into some really interesting discussion whether or not this is a phenotype, or is it a confusable disorder, or is it an overlapping disorder, and is it a cause, or is it effects? Is that the chicken or the egg? But at the end of the day, we didn't include pelvic floor phenotype in this discussion because a lot of the thing is based on a subjective physical examination. We can try to standardize the physical examination, but at the end of the day, it's very subjective. I want to have more thing objective before we can talk a little bit more about pathophysiology here. I know there's some emerging data on EMG and things like that. We actually done some of those studies, but we're going to focus on those 3 different phenotypes above. And this is a diagram that Max has nicely summarized, overlapping the 3 different phenotypes that we're going to talk about. And some of the features associated with these phenotypes, we talk about pretty much most of them already today. But it's important to recognize this concept of phenotyping, is these phenotypes can overlap. You can have a patient with Hunter's lesion and pelvic floor dysfunction. You can have a patient with pelvic floor dysfunction with widespread pain. You can have a patient with low bladder capacity with Hunter's lesion. You can have a patient with low bladder capacity without Hunter's lesion. So these things are not mutually exclusive. These phenotypes help you to guide the treatment, but they are not as distinct. and mutually exclusive as you would think. They do overlap. I think it's important to emphasize that when you try to identify the phenotypes and manage the patients. We've all seen this. We published an atlas of what Hunner's lesion looks like. These are what they look like. Typically, is an inflamed lesions that you can see on cystoscopy. It radiates from the center with vessels, and it has a red center. Typically, have actually some scarring, despite what some of the earlier literature that you've seen. There's actually some scarring, maybe because of the biopsy and the treatment that we've done with the Hunner's lesion. You can see this on office cystoscopy. Those pictures and the atlas that we presented was actually all the pictures that we've done with office cystoscopies. You don't necessarily have to do a hydrodistension of the bladder to see Hunner's lesion. The majority, you could see this in the office with flexible cystoscope without a major distension of the bladder to cause a lot of pain. However, there might be additional lesions that you could see if you start to distend the bladder under general anesthesia doing a formal hydrodistension. Now, you've seen all our literature using urine and different markers, maybe evolving into MRI, looking at bladder wall thickness, looking at bladder wall permeability with different contrasts on MRI. But as of today, cystoscopy is still the only reliable way to identify Hunner's lesion. And I don't think there's anybody in this room who would disagree that if you see a Hunner's lesion on cystoscopy, that patient have interstitial cystitis. I think that's pretty clear-cut. The guideline obviously tell us how to manage them, fulguration, transimmelone. Some people do TOR, you could do cyclosporin A. We're gonna talk a little bit about histopathology of Hunner's lesion and the markers, but you've already seen some of these data before. And obviously, if you send a specimen to our pathologists, they will come back and say chronic and acute inflammatory changes. Typically, it's a soup of mix of inflammatory cells, lymphocytes, activated mast cells, plasma cells, neutrophils, macrophages, and you typically see the epithelium being denuded. That means the umbrella cells protecting the bladder layer at those Hunner's lesions tends to be gone. I think most people agree on this. But you've seen some of this data before, and Yoshi talked about a little bit of it, is that patients with Hunner's lesion have what we call a pancystitis picture. Meaning that if you have a patient with Hunner's lesion, there are certain areas that clearly looks like a Hunner's lesion. There are other areas that looks relatively normal. If you do a biopsy of them, you actually see inflammatory changes among the Hunner's patient, even on those background mucosa that doesn't look like a Hunner's lesion. So in those patients, there's evidence, and histologically, there is a pancystitis phenomenon going on now. As to why you actually see certain lesions but not able to see the rest of the bladder that have pancystitis, I don't really know. But that is clearly demonstrated by this paper over here. The other thing that is very clearly obviously, as you can see on the pictures, is the Hunner's lesion obviously have denuded epithelium. The umbrella cells are gone. I think that's not a surprise to most people. And you've seen Yoshi also talk about cells that are involved in a Hunner's lesion. There are a number of good studies, I think most of them are from Japan, looking at different cell types when they did the bladder biopsies. There is clearly a clonal B cell expansion, maybe a little bit of a T cell too, so it's not just pure B cell, but it's also B cells and T cells, clonal expansion from those lesions. It begs the question, whether or not there's some kind of antigen causing these Hunner's lesion in the bladder, and at this time, we don't have any idea what these antigens are. Some of these patients have allergies. They are sensitive to certain dietary items or food or drinks, but we actually have no idea what these antigens might be. It might be nice to be able to identify some of those. Now, there's even studies where they take the Hunner's lesion, end-stage Hunner's lesion, when they did a cystectomy, and then they took this bladder out and look at different areas of the bladder, Hunner's area, non-Hunner's area among Hunner's patients, and then they was able to, again, see B-cell clones in a lot of these different areas in those patients. There's even other studies that look at IgE concentrations in the bladder tissue. As you would think, IgE is a response to some kind of allergen or some kind of antigen. It releases IgE immunoglobulins in the tissue. There's a study, is a small number of participants, so they have ketamine cystitis patients, they have Hunner's lesion patients, and they have non-Hunner's lesion patients. The limitation is a very small study, but clearly the IgE levels in the ketamine cystitis and the Hunner's group is much higher than the non-Hunner's group. Again, asking the question, is it possible there's some kind of antigen that we're seeing causing these inflammatory changes in the bladder, and we don't know what these antigens or irritants might be? So again, the level of IgE correlates to the pain scales, and it may be mediated inflammatory changes. We also have another committee talking about biomarkers in the urine. These are by no means the only biomarkers that has been shown to be elevated in Hunner's versus non-Hunner's from the urine. But if you look at that list, they are all cytokines, they're all chemokines, they're all inflammatory related, and it may be related to T cell function, B cell function, T helper cell functions, and things along that line. We did a systematic review, actually looked at a lot of these urinary markers, and a lot of them are quite convincing if you look at the meta-analysis that we have done. So that's the Hunner's lesion. I think that's the simple one. I think it's an inflammatory lesion. You can see on cystoscopy, we don't know what the antigens might be. They are inflammatory changes, pancystitis, losing the urothelium, etc. This is another one that you have talked about today. A lot of the work comes from Wake Forest here about low bladder capacity phenotype. Now, hydrodistension has been used as a therapeutic way to manage interstitial cystitis, and at least some patients respond in a short duration to hydrodistension with improvement of the bladder symptoms. It's typically, you don't use it for diagnosis, although some will argue you could do a hydrodistension to bring out the Hunner's lesion. I think some people will do that. And we heard about our colleagues, in other countries doing that as a diagnostic tool. But low bladder capacity may provide phenotypic information based on what we have learned from the studies coming from Wake Forest here. Now, the definition of what constitutes a low bladder capacity during hydrodistension, I think it changes a little bit over time. Initially, it was less than 400 cc with hydrodistension. Now it's more about 500. I think that criteria, how you stratify it, depends on the clinical presentation, the molecular markers, and the genetic makeup to try to optimize where you draw the line. I think it's 500 now, is that correct? Yes, thank you. So patients with low bladder capacity has been shown to have worse symptoms, worse urinary symptoms, more severe pain, increased urinary frequency, whereas the one with large bladder capacity tends to have more non-bladder-centric presentation. What do I mean? Psychosocial problems, depression, endometriosis, irritable bowel syndrome, things along that line. So you clearly again see this distinction between bladder-centric phenotype and non-bladder-centric phenotype using this stratification, using bladder capacity as a way to define them. You have seen this diagram before. This is the molecular profile of gene expression from patient with bladder biopsy. The low bladder capacity one have inflammatory genes. It clearly looks different from the one with high bladder capacity. In fact, they look more like control. Again, there's a small number of subjects over here, but these kind of things has been kind of been reproduced over and over again. So it's reasonable to say that, okay, patients with low bladder capacity have more of a bladder-centric presentation, whereas those with higher bladder capacity on hydrodistension will have a more systemic or less likely to be a bladder-centric phenotypes. I think it's reasonable data. Now, we also heard about widespread pain, talked quite a bit about it today, and you've seen this body map. As part of the MAP study, we give this body map to for our participants, so that includes our controls, our men and our women with both interstitial cystitis or chronic prostatitis. So this kind of data apply to CP-CPPS also. Among the men and the women, if you combine both groups, overall, only about a fourth of the participant only reported pelvic pain on the body map. In fact, 3/4 of them have pain outside of the pelvis, And half of them, that's more than a third of the participants, actually had widespread distribution of pain. So we define this as 3 different body regions. So you can have the head, the left arm, the right arm, the left leg, the right leg, the front side of the body, and the back side of the body. There's 7 body regions. If you have 3 or 4 body regions involved in pain, we call this widespread pain. And you could clearly see the different phenotypes over here. Now, the implication, we already talked a little bit about it by some of the other committees. A lot of these patients typically have what we call chronic overlapping pain syndromes or other chronic pain conditions. Fibromyalgia, IBS, chronic fatigue syndrome, migraine headache, vulvodynia, etc. They also have other things unrelated to pain. For example, they have fatigues, they have difficult time sleeping, difficult time concentrating, very sensitive to external stimulation or internal stimulation, such as light, odors, and things along that line. These patients typically is believed to have centralized pain phenotype, or another way that you may have heard the term is nociplastic. That means the pain appears to be centrally driven instead of a down-up phenomenon. The pathophysiology may be a top-down phenomenon, and the bladder tends to be, and perhaps it's just a bystander of one of the many pain syndromes that the patient have. So if you think about it, this likely is a systemic process, is top-down, is driven by something else happening outside of the bladder, even though they complain about bladder symptoms. If they walk into an office of a urologist, they might talk about frequent urination and bladder pain, and you label them interstitial cystitis. If they come and see a rheumatologist, they may label them fibromyalgia. If they go to GI, they may label them IBS. Maybe we shouldn't be doing this to these patients. Maybe we should call all of them something else other than all these terms, plus this and plus this and plus this. Okay, how stable is this phenotyping effort? In other words, we've all been kind of taught that, okay, a patient starts with a problem in the bladder, maybe it starts with hypersensitivity, a urinary tract infection, the bladder is sensitized, you start with bladder pain, and over time it becomes regional pain involving the bladder, the pelvic floor and things along that. And then over time, you develop quote unquote central sensitization, and then the pain spread from the bladder to the pelvic floor to everywhere in the body. I mean, we've been taught about this possible, migration from one stage to another. Is that really true is the question? Or do they actually start off parallel, that you're not really going from one phenotype to another or progressing from one phenotype to another? Because for your phenotyping concept to be acceptable, you can't be moving around these groups all the time, because otherwise you're not talking about something distinct of a distinct pathophysiology. So what we have done is, in the MAP study, we classify the patients with pelvic pain only or widespread pain. We follow them for 12 months. We assess the pain distribution on the body map multiple times during this 12 months period. The number of people that migrated from pelvic pain only to widespread pain is very, very small. Only about 2% of them actually do this over the course of 12 months. The number of people who started with widespread pain and then somehow becomes pelvic pain only is very rare, 6%. It is a short time frame. We're really following them up for 12 months. And a lot of these people have chronic pain already, so we're not picking up at a very, very early stage when they have a new onset of bladder symptoms. So we cannot rule out this possibility of migrating from one state to another, but the data doesn't seem to support that people migrate from a pelvic phenotype to a widespread phenotype given them time. Andrew have done a lot of really good work on this, on inflammatory phenotypes. It is not just, we'll show you the MRI data, but it also appears to involve a systemic inflammatory reaction with upregulation to toll-like receptor 4 inflammatory response. In fact, the people with widespread pain have more TLR4 mediated systemic inflammatory response against the one that have pelvic pain only. So you got to think beyond just a brain changes associated with these people. There might be some systemic inflammatory process going on driving these different pain occasions in the body. Many of you have seen the MAP studies, and there's a number of neuroimaging studies published by the MAP, comparing controls to UCPPS. And I think the bring home lesson here is that the people with widespread pain, whether or not they have chronic prostatitis or interstitial cystitis, if you look at the brain signature on a resting state MRI or a structural MRI, which is diffuser tensor imaging DTI studies, those people with chronic pelvic pain that have widespread distribution of pain, they really look like a fibromyalgia patients in terms of the brain signature. So again, this reinforces the idea there may be some kind of top-down phenomenon going on, because fibromyalgia is really a prototypical syndrome of nociplastic pain with central sensitization and affecting other functions in your body. They really don't look like people with localized pain. The brain signature is totally different in this group. Now, all of this is nice if you have the different phenotypes, and we could argue to the end of the day how we define the different phenotypes and how many phenotypes there are, and what is overlapping, and what is exclusion, and what is a phenotype, etc. But it has to have some practical values in helping you to manage your patients. We need to go from phenotyping to therapeutics, because if we cannot bridge this gap and help you to optimize the treatment of the patients, then the phenotyping exercise is only halfway through, is a cup half empty. We wanted to move to the next stage to try to figure out whether or not we can individualize the treatment or optimize the treatment of our patients knowing the phenotype. The underlying hypothesis behind all of this is that you identify the different phenotypes in the different subgroups, and you think that each of the subgroups have different underlying pathophysiology that are different and distinct, and you can find drugs or treatment with a mechanism of action that target this specific pathophysiology in the phenotype. And with that in mind, then you could optimize the treatment, because you could target treatment A is phenotype A, treatment B is phenotype B. This is really the overall goal or where we wanted to be heading here. You may have seen this paper, and you may have seen other people talk about it this morning. The question we wanted to ask as part of the MAP study, reviewing previous literature, is whether or not patients with widespread pain respond better to systemic treatment, and whether or not patients with more localized pain respond better to localized treatment. You have seen some of this data before, and the answer is yes, and I think that's encouraging. So what we have done is we looked at the previous clinical trials, randomized controlled trials, or two different treatment. One is systemic treatment, one is a localized treatment. We show that for the localized treatment with hydroxyzine and pentosan polysulfate, the patient with localized pain, the signals separate out. Whereas the patient with widespread pain, the localized treatment didn't help them against comparing to the placebo. It is a reverse story with amitriptyline. It has a systemic effect of helping you. So patients with widespread pain to begin with responded better in terms of the effect size and is separated from placebo, where those with localized pain, they don't seem to do much better with amitriptyline. The placebo and the drug looks the same. Now, these are retrospective review of published literature. I mean, you're looking at previous data. But again, it's encouraging for us to base on this and think about, okay, what can we really do to try to use these phenotyping data to help us to optimize the treatment in future clinical trials, or maybe we want to do a multinational, multi-site registry study or clinical trial among everybody here who can help us to really optimize the treatment of ICBPS patients using the phenotyping information and the different treatments that are available in our clinical armamentarium. So this is the summary. I'm going to stop here and answer any questions. And thank you. And Larissa, you can feel free to come up if Laura wants to come up. I joke about earlier, Quentin is the first one to go. So all the questions have already been answered by Quentin. All the difficult questions has been answered by Quentin, being the first one up.
Hi, Latasha Crawford, University of Wisconsin-Madison. I just had a quick comment and a little bit of a question. I noticed that one of the things that comes up a lot when we talk about widespread pain is this kind of central sensitization, this kind of top-down. And I wondered if for your committee and your literature search, or something that we can maybe throw open to the audience, to what degree has the discussion of the potential of peripheral sensitization kind of come up, where it doesn't actually involve the brain per se, but it does involve, for example, the sensory nervous system, dorsal ganglia, and kind of nerve endings, and some of the plasticity that involves there, which could certainly be multifocal, if not systemic. And I was just kind of curious if that's something that's come up, or if that might be an opportunity or a gap that can be addressed by
So my
our group in the future.
interpretation of your question, central sensitization, peripheral sensitization, egg and chicken. Dan, do you have any thoughts on this? The interface between central sensitization, peripheral sensitization, when does pain becomes chronic?
Yeah, that's a really good question. And certainly if there is any nociceptive stimulus out in the periphery, you often do see both peripheral sensitization and central sensitization. And when we talk about nociplastic pain, we talk about the other form that is more bottom-up. So a third of patients with autoimmune diseases like rheumatoid arthritis or lupus will also have fibromyalgia or nociplastic pain, and we think that's being more driven by peripheral nociceptive input. So you do, especially in the people with ongoing peripheral nociceptive input that have nociplastic pain, you often see both peripheral and central sensitization.
Thanks. That could be a good thing, I think, to add in to the mix here. Thank you.
Thank you.
I have a question, and I will give the caveat that I'm a veterinarian at the beginning of this, so that is the lens that I am approaching this from. But your high IgE piqued my interest because there's a histologically distinct lesion, which is eosinophilic cystitis, which you would expect high IgE levels. And in order to diagnose that, you have to biopsy because you often don't have a systemic eosinophilia. So if in the criteria for ICBPS, you're not biopsying, how are you excluding eosinophilic cystitis in patients?
If you're not biopsying, I don't think you can even exclude that possibility. Any thoughts from audience with eosinophilic cystitis? I don't think there's any distinguishing features that will tell you separately, right?
You need a biopsy.
Yes.
Mm-hmm. But her point is well taken, and there's clearly those patients that have inflammatory lesions that aren't responding to your standard, cyclosporin and things, and you do see eosinophilia. Problem is we don't really have the drugs available to us like they do with this eosinophilic esophagitis to treat them. Oh, sorry. My big voice.
This is great. Just a comment on, looking at central versus widespread versus localized. I try to treat patients with this algorithm, and it's really hard. This is just sort of an aside, but it's very hard to get patients with clear widespread pain, multiple NUAS or chronic overlapping pain syndromes, and it's very hard to get them to take Elavil, I found, or they'll say, oh, it makes me too sleepy. And so I think that really limits what we're able to do when we take these phenotypes into account.
Hi, wonderful, Henry. Just wanted to ask one question regarding, since my job was to have sexual differentiation between the two, which one of these two phenotypes, the widespread pain or the localized pain part, which had the predominantly male or female component?
I do believe the widespread pain has more of a female predominance because as typically the nociplastic populations of patients with chronic pain syndrome tends to be much higher in females compared to males. But with respect to pelvic floor and things like that, I think men pelvic floor dysfunction has been underappreciated because we don't like do a rectal and feel that we should do a good transrectal examination and feel the pelvic floor. Like most of the practicing urologists won't do it. So that one I suspect might be, maybe it's 1.5, maybe it's close to 1. I don't know for the localized phenotype.
Just in response to what Jennifer was asking, treatment of widespread pain syndrome, it's a widespread treatment also. It is not one pharmacological agent. So you have a lot of things to do to treat together. It's a multi-pronged attack on the disease. Thank you.
And one thing I think it might be worthwhile to bring out is that I do cystoscopy on men, and we do see Hunner's lesion in men, so it's not a female exclusive phenomenon. So that's why I think in men you might want to do cystoscopy more often than usual, because I have actually personally treated the patient for 2 years for what sounds like interstitial cystitis. It turned out he had a 2-centimeter bladder stones, and I laser the stone and all the pain is gone. So I feel kind of okay that I missed this big boat. So
thank you,
this is
Henry,
possible.
for that comment, because the AUA has been saying you should do cystoscopy only if you suspect Hunner's lesion, and they talk about women older than 40 or older than 50 years. Thank you so much for that comment.
Actually, it's easy to distinguish the low capacity bladder and like Hunner's lesion phenotype. Now, I don't understand that, see, initially, like maybe some 10, 15 years back, by low capacity we meant was something 150 or 200 cc capacity. Now you are talking of 400, 500. So what is the clinical significance of that low capacity? Number one. And my other question is, when we talk of localized pain and widespread pain, so in widespread pain you include intermediate pain. And intermediate pain is more of like gastric pain, gastritis or back pain. So most of the patients, even if they have localized pain, they complain of gaseous pain and the back pain. So if you include both of them, it comes to around 60 to 70%. So, and it's, I don't know, but I have been treating patients, and you all have been treating patients. Is it really so easy to differentiate? I think there is a lot of overlap. And we also do cystoscopy in all the patients. And you don't do cystoscopy in all the patients.
So go back to that questions about the intermediate group that you were talking about, right? So when we kind of saw this data initially, we thought, okay, maybe we could just have pelvic pain and then pelvic pain and beyond. But we wasn't sure what to do with this intermediate group, because anybody who has in the 50s or 60s or will have some kind of chronic pain. You can have back pain, you can have headaches, you can have neck pain, you can have a number of things. So what is your criteria, or what's your threshold to above which you would call widespread pain? So initially when we did this, we separate into the 3 groups where there's a widespread pain, but we don't know exactly what to do with this intermediate group, because a lot of common people will have that too. They don't have to have IC, right? So that's kind of how we did it. I think Quentin subsequently validated that if you have 3 regions or more in your body, that will be a better criteria for widespread pain. And the intermediate one, I'm not sure that will classify as widespread pain. We shouldn't be doing it this way, if that's the questions you're asking about.
If you look at I think the intermediate region, then it's mostly back. And gas, I think.
The back and headaches.
So that's very common. That's very common.
If you go out to the general population, those are very common. That's why we didn't think that will be enough to be called widespread pain. We kind of just draw that out.
Because my biggest question is how to differentiate, this phenotypic differentiation. Because if you don't have an objective, this thing, if you have an objective, it is fine. But subjective, it's very difficult to differentiate different phenotypes. Low bladder capacity, yes, you can always diagnose. Hunner's lesion, you can diagnose. But what about this pain and all these things? I think it's difficult to diagnose. You didn't answer that 400 cc capacity. What's the clinical significance of 400 cc capacity or 500 cc capacity in here.
Bob, you wanted to answer that question? 400, 500 cc capacity?
Well, Steve might be able to answer it better since he did some statistical analysis, but we broke everything down in bins, and that's where it's separated out better in terms of bladder-centric versus systemic. But I think the thing that's so important about the capacity question is that if you're trying to treat somebody's frequency and they have a 1200 cc capacity, it's a completely different situation than if they have a 400 cc capacity. End of discussion.
Just circling back to going back to cystoscopies and things like that and biopsies. We were just talking about eosinophilic cystitis, and I had mentioned earlier in one of my other questions about different forms of inflammatory disease. We see a lot of, nephrogenic adenomas. We see, again, just lots of other inflammatory pathologies that can actually produce symptoms of bladder pain. A classic one in the younger patient, obviously, is ketamine cystitis, and that group of patients don't like to give it up, tell you about it. So the question for you is basically, in terms of phenotyping, what's your opinion or your group's opinion, if you discussed it, as far as actually biopsying these patients? Because we really haven't sort of solidified what we're doing. I mean, we talked about doing it perhaps in all patients and hydrodissensions, but at the very least, the question is whether these patients do require biopsy to get a more definitive diagnosis here. I mean, I personally do it. I like to know that there's no carcinoma in situ, and et cetera, but again, did you discuss it or planning on putting it in your manuscript?
No, we haven't discussed the role of biopsies in this phenotyping effort, not in the manuscript. I think it depends on, I think it depends on what you're trying to achieve here, right?
Right.
If you're trying to advance the field to try to better understand the pathology and the different cell types and the clonal expansions and all that kind of stuff, you should biopsy it as part of a research study or moving the field forward. I don't know what you're going to use those biopsy data to guide treatment. Today, we don't know yet, but you can gather the information and that could be useful for the future. I'm not sure you want to biopsy every single patient who come to your office and not necessarily from a science or research perspective, but just from a cost perspective. It's prohibitive, it's invasive, and what do you get out of it other than ruling out CIS?
The reason I asked the question also is because just historically, we've been very wishy-washy on biopsy on these patients. ESSEC was very, very definitive about doing biopsy on every patient, but the AUA guidelines are very, very nondescript. Basically, if it's a, quote, suspicious lesion. So at the very least, at least in terms of consensus here, to at least come up with some, patient, some index patient, for example, where nobody would ever argue that patient would benefit from a biopsy. That's all.
I guess you got to think about consensus to do what? Consensus for future research, consensus for common practice.
Well, in this case, to rule out other pathologies.
Yeah, that's reasonable. Yeah, that's totally reasonable. Okay, thank you.
All right, thank
you. The next group, Laurie Berder is going to lead the therapeutics. At least some solution coming at the end of all this discussion.
No. I hit the wrong button.
It's okay. It's a little finicky. It's not you. It's the computer. Promise.
Thank you. Okay, thank you very much. So as mentioned, I'm going to be presenting on behalf of our committee. Just want to give a great shout out to Karis, who's done a really great job and heroic job in putting together the manuscript. This is on therapeutics. So in terms of an overview, just to note that this isn't in any particular groupings. So we're just going to be talking about the following interventions. First of all, conservative management, the first-line treatment. These can consist, there may be others, but lifestyle modifications, dietary and certainly fluid management, bladder training, obviously stress management, which can, chronic stress obviously plays a big part in triggering these symptoms, pelvic floor physical therapy, oral medications, obviously pentosan polysulfate, Almiron. This is the only oral medication that's FDA approved, but it has been associated in some patients with some vision loss, this pigmentary maculopathy, which may be obviously problematic and something to consider. Tricyclics, such as antidepressants, have been used. Combination of amitriptyline with other therapies can reduce some of the possible side effects. The P2X receptor antagonist. This is shown to have some efficacy in years past, but no further information this has been stopped. Silodosin improves both abdominal pain and bladder frequency, so that has been used. A number, this is just a partial list in terms of pain management, so this obviously depends on the patient cohort, anywhere from nonsteroidals, acetaminophen, centrally acting agents such as gabapentin for certain chronic pain conditions have been used. In terms of immunotherapy, cyclosporin, and that's something that we can discuss more in terms of the chapter. Tacrolimus has been used in some patients with intractable IC. In terms of immunotherapy, there have been a few that have been shown in years past. Efficacy, anti-nerve growth factor has been used, and as well as TNF alpha blockers. But more research is definitely needed to determine both efficacy and also safety. There are a number of intravesical therapies that are being used. There are advantages, obviously local concentrations. This eliminates a lot of the systemic side effects. There can be rapid reduction of pain, urgency, and frequency, but obviously a number of disadvantages, including repeated catheterizations, possible frequent clinic visits, and the potential for even no symptom relief in some cases. But these can include DMSO, lidocaine, obviously a number of gag layer substitution therapies. There are intravesical injections, such as botulinum toxin, although not FDA approved, has been shown to have very promising results for reducing bladder pain, and trigger point injections, which we've gone into more detail into the chapter as well. Neuromodulation, sacral and pudendal neuromodulation has been shown to have some benefit. In many cases, can block C fiber activity, even reducing pain-inducing mediators. There are a number of promising therapies, such as low-energy shockwave therapy, either given alone or combination with Botox, has been shown to have some efficacy. And platelet-rich plasma is promising. Some groups, like Professor Guo in Taiwan, has been used this quite a bit. It tends to be very expensive. A long list of experimental therapies, preclinical, such as anti-VEGF, gene therapy, targeting cannabinoid receptors, PNPase inhibition, and as well as anti-fibrotic therapies, has been shown to have some benefit, at least preclinically. There are also a number of novel intravesical therapy delivery systems. Some people say it has benefit, others do not, such as thermosensitive hydrogels, has a high mucosal adhesion. Liposomes have a very unique structure. Empty liposomes has been shown in patients to have some benefit, although unfortunately encapsulation with botulinum toxin has shown no efficacy. There are a number of therapies that have either not demonstrated efficacy or have been terminated. and this is just a partial, very partial list between phase 1, phase 2, and phase 3, unfortunately. There are a number of limitations to many of these investigations, which can include, and I think we talked about this earlier today, small sample size. The patient populations tend to be heterogeneous. We need to really standardize a number of outcome measures, what we're going to be looking for, and obviously extent of overlapping pain conditions. Other points that we asked to consider, the rationale for a large number of treatment types. Is this due to lack of understanding or pathophysiology, industry influence, or other? Could a combination of various treatments give better outcomes, at least in some patients? If a treatment is initially successful, is the effect long-lasting? And what about gender differences? So these are some things that we're considering also in our chapter. And Ken will then take over the discussion.
Thanks. While people come to the microphone, just show of hands here. How many people routinely use cyclosporin for Hunner's lesions, IC? And then how many still prescribe pentosan polysulfate as a primary treatment for IC? And what about intravesical therapies? How many use them as a routine thing in their practices? All right, that's an interesting thing to see. All right, Curtis, go for it.
Okay, so I'm going to start off. This was a very nice list of ingredients. Now, my wife has every ingredient you need to be able to make a great meal. And she'll set me up and leave, and she'll give me a recipe book. And she'll say, you know, make me a Michelin star dinner. There is no way I can make with the ingredients, even if I have the Michelin star chef recipe book, I can't make that meal. And this is the same thing. We have the recipes, the guidelines. We have all the ingredients. I mean, these are all the ingredients we have. We have no more. We have to put these ingredients together and make the urology equivalent of a Michelin star treatment. And that's what we have to strive for. So the real effort now shouldn't be testing all these things. It's learning how to use what we have in our patients that see us tomorrow. And the way to do that is, you know, I can spout this forever, but the way to do that is to look at the phenotypes and then individualize a treatment recipe for each individual patient based on that phenotype, and then direct that therapy with realistic goals. And then what we'll do is we'll become actual Michelin stars in IC-BPS treatment. So I had to just say that after
That's
this.
perfect. So tell me your recipes.
Pardon? So I actually published my recipes last year because, you know, I get emails every week about how do you treat this patient, that patient, and I was getting tired, especially now that I'm retiring, in answering it. So what I've done is I put together a recipe book. It's available online, free, of how to treat all the individual patients that I see in clinic over the last 40 years with a 90% success rate. And what's the success rate? Patient leaves happy that they saw me in the first place. You know, go figure. I don't think in my lifetime we are going to find the magic bullet for this condition we call IC-BPS, and that was just shown, you know, in this. So what we need to do is use what we have better.
Just seeing you would make me happy too, Curtis. You're so enthusiastic always that I'd be like, yeah, that was a good visit.
Curtis, you're like a stopped clock. Sometimes you're right twice a day. That was really well put. I'm impressed. Unusual, but I'm impressed. I just want to point out that the phenotype that's most prevalent is epithelial dysfunction. They have lost the permeability barrier, and it leaks, and you get potassium. That's most of the patients, that phenotype. And so we know from both rodent and human studies where we destroyed the epithelium in normal subjects, we could repair it with heparinoids. We need to focus on treating the cause, the initial cause, the leak. And if you don't, you won't be successful. You can poison the inflammatory system, you can poison the nerves, but it's still going to leak. They're going to do badly. We have to get better methods to put higher doses of drug into the bladder, whether by mouth or with a catheter. And I would emphasize, stay away from chondroitin sulfate and hyaluronic acid. Not that they won't work, but they're very expensive. But pentosan polysulfate is the cheapest heparinoid in the world. I mean, the doses that are now prescribed, you could triple the dose, and it would, and to make it would maybe be $10. So focus on the expense and putting a lot into the bladder and on a daily basis. You can't give it intermittently because the factors that are entering the mucosa are in the urine. They're urinary amines, and they're there 7/24.
I wish it was that easy, and I don't agree with you that everyone has an epithelial barrier dysfunction. I certainly don't agree with you that pentosan polysulfate has been the answer to it. And nowadays, I think with the issues, every study on pentosan, remember, when you published the first study, 85% of patients got 85% better. And then we added a placebo, and it was markedly less after that. And every study using that afterwards has really shown no significant benefit. Now, to your point of putting it directly in the bladder, whether it's heparinoids or that, maybe, but it would be great if you could load it into one of those pretzels like we were doing with lidocaine, and you just get a continual secretion and see if it helps that subset of patients that have an epithelial dysfunction. But I'm not convinced that who we call IC, I'm not convinced the majority of them have an
I respond
dysfunction.
two ways to that. You say they don't have an epithelial dysfunction, show me data.
Well, show me the data in all the patients we talked about today.
I'll show you the data tomorrow.
Because potassium means nothing to me because I've seen bladder cancer with potassium, I've seen UTIs with potassium. So it isn't defined that it's a benign epithelial dysfunction.
I will show you data tomorrow.
Okay.
Lots of data, 45 publications.
Well, then we
worth.
should have figured this out by now.
And number two, the doses that pentosan people use for a few weeks is low. I'm talking triple the dose. You triple the dose of pentosan, you get great responses, but it takes time. It may take 2 years for a severe patient.
And I'd say show me that data, because I remember you 15 years ago up at the microphone saying the same thing. And you say pentosan polysulfate's so cheap, but it's been one of the most expensive drugs for IC out there.
And that's why I use the generic. I don't use the drug anymore. The generic is about 90% cheaper. It's cheap to make. That's the whole point.
Yeah.
So you can get it. And there's a company that makes it in India very inexpensively.
Yeah, just a really quick comment from the widespread pain field. If you're going to use a tricyclic to try to treat the widespread pain, cyclobenzaprine is a really effective drug. It's going to be approved later this year. Low dose nighttime cyclobenzaprine for use in fibromyalgia. But you can, if you live in the U.S., you can prescribe it. It's Flexeril. But 5 to 10 milligrams of cyclobenzaprine a couple hours before bedtime is by far my favorite tricyclic. It's a lot better tolerated than amitriptyline or nortriptyline, but people don't think of it as a tricyclic because it was originally marketed as a muscle relaxant. So, it can be a really helpful drug to try in people with widespread pain.
And does it cause weight gain? Because I think that's a pushback.
Not because again, you're using 5 to 10 milligrams at bedtime. It's not as
bad.
likely to cause a weight gain as some of the other drugs. So it's my favorite drug for fibromyalgia.
All right, cool. Definitely I'll try that.
Ken, just a quick question. Any reason why there was no mention of antihistaminic therapy? I didn't see any.
Yeah, it's actually in our paper. I didn't see it up there either. Certainly antihistamines, there's data with it. I think there are those allergic components of IC, and you see those flares sometimes in the spring and the fall, but I use hydroxyzine a lot. Elise, I think you were next.
I really like the comment about widespread pain, and I think we need to be able to provide the definitive document and really drill down on all of these things, but we also need to provide guidance to the world. I think the reason people avoid patients with pain is because it's so hard, right? So, basic idea is when we have a patient with widespread pain, then we're going to be thinking more about neuropathic pain treatment, amitriptyline, gabapentin, cyclobenzaprine, apparently. What are some things you can offer these patients while at the same time you're treating the bladder pain as the Michelin star? And, if you have a patient with widespread pain and they're found to have small fiber neuropathy, then they may have dysfunction of the sympathetic nervous system at the bladder neck, and therefore bladder neck obstruction, and therefore they may benefit with alpha blockers or Botox to the bladder neck. So I think we need to give basic instructions for widespread versus local, and then sort of options and how people should be thinking. You can even do IV lidocaine in small fiber neuropathy, and provide practical guidance to the average urologist at the same time that we're really looking for directions for the future and how to mix methods.
Yeah, I agree with you. And I think you could have widespread pain with very distinct things as part of that to treat, like, distinct triggers to try to downregulate or take away some of the triggers that they have. But it is a challenge, and you're right, this is why people don't want to take care of it, because it's not easy to do. But we do got to kind of look beyond it all.
And last comment to take offline, I think we have work to do on the central and peripheral sensitization and their relationship. And also, can you call it IC if the patient has small fiber neuropathy or not? I think we have to make a decision about that as a group.
Yes. Yes.
Yeah. So, as Curtis has rightly mentioned, we have all the ingredients. The most important suggestion is that we should not discard any of those ingredients. The reason is that if you look at any of those studies where in one study there is a response, in the another one there isn't, there perhaps is a difference in the recruitment criteria, and they are not the same population who have been treated with the same ingredient. So whenever we are about to discard a treatment, we must test on what studies did it fail, what was wrong in that study that it failed. And the same goes for the pendozan polysulfate. So Curtis has few papers, Parson has few papers. I reviewed the role of pendozan polysulfate, and what I realized was when you had cystoscopy as an essential inclusion criteria for pendozan polysulfate, it worked. In all the studies where it was not used, cystoscopy was not as an inclusion criteria, the drug didn't work. So that is an example of what I wanted to present, that we should not discard any of these ingredients without analyzing why it failed.
Just a quick question back to you, because so on cystoscopy, what is it that you would see?
If it is a bladder-centric disease or it is a non-bladder-centric.
But based on what on cystoscopy?
So
Size?
based on four things, yes. The bladder capacity, the Hunner's lesion, the glomerulations, mucosal cracks, and these are the four things.
Okay, and then I agree with you. I don't think any of them should be discarded, but I think Curtis is right, though. We need to break it into the different phenotypes and say, for this type of phenotype, these are the things that behavioral and stress reduction and psychosocial, all that's important in everything. But
because the last slide, what Laurie showed, had some molecules which it said they don't work.
Right.
So before we discard them, we'll go back and find why they didn't work.
Yeah, I think unfortunately it isn't that they don't work, it's just that nothing is successful because we have too heterogeneous of a population. When we're testing something, we don't know how to pick the right patient for the right drug. That I think is the issue. Yes.
I would like just to call your attention on a really important take-home message of this meeting. In 2025, local installation therapy does not mean automatically a catheterization. You have to know there's an option to give the installation completely pain-free, with the advantage, the simultaneous treatment of the bladder and the urethra. And this is the Urodapter. It's available in many places.
We just started using it.
In Europe, we use it since 6 years. And the patients love it. So,
do you know what the Urodapter is? Do you all know what that is? Instead of like a catheter going in, it really just goes at the urethra, right? It attaches to the syringe.
Just the tip.
Yeah, it's the tip.
Is placed into the orifice, and then the liquid flows through the urethra into the bladder without any mechanical damage to the urethra.
Yeah, because then you're just flaring them with a catheter a lot too. Yes.
Hi, Laura Santuri. I'm with the Interstitial Cystitis Association. I'm also a patient with widespread pain. My question is, what is the responsibility of this group having this discussion today to come to some consensus on recommendations around non-pharmacological treatments and multidisciplinary care for people like me?
I think it would be laudable if we do that. I think multidisciplinary care, like, something, like we opened a comprehensive multidisciplinary clinic back in 2010. And because I learned a long time ago that staying in our little silo, we don't do a good job. And I do think, making a point of a multidisciplinary team, because when you have different subspecialists in all the different fields that address this, look at patients and you look at the different triggers that can be causing this, I think we do a lot better at treating. I mean, we always say in our center, the mind, body, spirit, the whole thing, because there's so much involved. So I think it is something we should put at the top of our list as far as, a multidisciplinary approach. As far as other treatments for like systemic type pain, it becomes, it becomes difficult of where the line is between kind of treating. I know people are getting like ketamine infusions and stuff. I don't feel comfortable as a urologist to go down that route right now, but it may be that, recommend referral to, a pain clinic that would be able to offer either different types of nerve injections or, ketamine infusions or spinal cord pumps and things like that,
Yeah, I think if you look at the guidelines and that whole category on behavioral and non-pharmacological interventions, education is right there. One of the things I would love to see is some more evidence-based around those types of behavioral interventions and the different professions who can provide them. So,
yeah, I think it's very good.
Yeah, so there's the multidisciplinary adjunctive care, and then there's multidisciplinary allopathic care. And I do think if we're creating a guideline, we have the responsibility to make that standard of care and to encourage improved insurance reimbursement for that multidisciplinary care, because ultimately, when patients improve, they become less expensive, and that's the goal.
The problem is and the hard thing is not everyone has the resources to be able to put together like a team, have enough people involved in their health system or in their practices for multidisciplinary. But it shouldn't stop us from, basically recommending that this is a good, a good method of care and that we should advocate for.
Yeah, they don't have to be all in the same room, but it would be nice if people
You had a
could
consortium.
get hooked up in the beginning instead of waiting for one at a time.
All right, one more just quick question, because I'm curious. How about intravesical Botox injections for IC? How many people use that? Yeah, it makes me nervous because I always think, man, if I put them in retention, they're not a happy person. But I know that there's that. I'm coming around to it. I just haven't quite got in there. Comment about it?
No, Abby did not come in because we won't talk about it for off indicated. I really encourage them to come and discuss this topic.
Well, I think, so we were part of the trial, because it was part of the trial, but the placebo had more effect than the drug. So I think some of our, Len, I don't know if you want to comment, but I think that's what it's showing, is that it's not going to be better than placebo. Placebo actually, though, did very well. It was like 40%.
Placebo works for everything.
All right, so there is a scheduled break, and for the tea lovers, there is tea now available, and including hot chocolate, if you don't like coffee. 15 minutes, we will start at 3:30 again. Curtis is going to describe his dish.
Still freezing? Doesn't feel quite as cold. Warm you up? I might get hot chocolate.